Good afternoon, everyone, and welcome to our webinar, and thanks for joining us this afternoon. I'm Angela Jones. I'm the Chief Operating Officer for Monash Partners Academic Health Science Centre based in Melbourne, and it's my great pleasure to welcome you this afternoon. The topic for our webinar today is pressure injury prevention and management in patients with a BMI of 30 and over, and we've had really strong interest. Clearly, this is something that's a great challenge for clinicians working on the front line, and so we welcome you today. We're delighted to be joined by two very distinguished presenters from Queensland, Dr. Sharon Latimer and Professor Brigid Gillespie, and it'll be my pleasure to introduce those to you in just a few moments. We begin by acknowledging the traditional custodians of the land and waterways on which our Australian partners stand. We pay our respects to these cultures, their elders past, present and future, and continue to uphold their ongoing relationship to the land. I'd like to personally pay my respects to any Aboriginal and Torres Strait Islander people joining us for this webinar today. For those of you that may not know a lot about Monash Partners, we're a partnership of 12 organisations, 7 health services, 2 universities and 3 medical research institutes. Collectively, our partner organisations provide for the health and wellbeing of about 3 million Australians. The combined research budget of our partner organisations is just over $300 million. Across our network, we encompass 57,000 health professionals, and to date, Monash Partners has funded about 85 projects, collaborative projects across our network. Our purpose is to connect clinicians, researchers and the community to innovate for better health for around 3 million Australians and beyond. We know that our healthcare sector is very siloed, and Monash Partners plays a key role in connecting people for genuine healthcare benefit for our community. We focus very much on the priorities of our community and our health services. Just to let you know, today we'll be audio and video recording our session, and we'll send you an update and make it available post the event on our website. We'll be monitoring the chat throughout the session, and we would really welcome your comments, also your questions for our speakers via the Q&A. If there's a question that's there and you'd like to prioritise it, you can do so by just clicking the thumbs up. These are our social media handles, and we welcome your input into today's session. It's now my great pleasure to hand over to Dr. Victoria Team. Victoria has been working with the Monash Partners team for a couple of years now. Victoria is a public health researcher who currently coordinates a number of programs at Monash University focused on evidence-based practice in venous leg ulcer management. She has a lot of strength in development of education materials for patients, carers and clinicians. Victoria has been funded through Monash Partners to lead a wound care initiative across our network. Wound care is a priority for our current Minister of Health. It's my pleasure now, Victoria, just to hand over to you to provide a little bit of background about some of the work you've done and set the scene for Sharon and Bridget's presentation. Over to you.
Thank you, Angela, and thank you everyone for attending this webinar. So, Angela, can you please move to the next page straight? As you see, it's the web page of Monash Partners Education, Training and Events. And you have seen many resources and courses that Monash Partners runs, and I'm sure that many of you have attended at least some of these courses and accessed their resources. And I'm happy to let you know that we have developed an additional resource on pressure injury management. So it's highlighted in yellow in the end of the page. Can you please move to the next slide? I would like to acknowledge the input from Professor Carolina Weller, who helped me to develop this resource. And I would like to acknowledge Monash Partners Steering Committee on Pressure Injury Surveillance and Prevention, for their input as well. We have conducted a lot of interviews with the clinical leads and also with individual nurses, and we have identified the main themes of interest. And I also would like to acknowledge the financial support by the Australian Government Department of Health's Medical Research Future Fund. And also I would like to thank Gillian, Amanda, and Monash Partners IT team for helping to develop this website from the content that we have developed. Next slide, please, Angie. Well, I have included the web link to our pressure injury resource, and we believe that this resource will be of interest to many clinicians who would like to improve their knowledge and practical skills in pressure injury prevention. This resource also includes a dedicated module for patients, carers, and families. This resource is available at no cost, no subscription is required. It could be accessed at any time. It has 5 modules which could be completed at any time, and if people have interest at any specific modules, they can just complete any individual module they would prefer. This module doesn't replace the compulsory induction or professional development courses recommended by health services, but rather complements these courses. Next slide, please, Angel. So as I said, we have developed 5 modules. Module 1 is the introductory module to pressure injury, and we have included a lot of useful links to the guidelines and other important resources, evidence-based resources, the latest resources on pressure injury prevention and management. Our second module is more on classification, on differential diagnosis, and on diagnosis of pressure injury, with a lot of practical suggestions on how to differentiate different stages of pressure injury. Module 3 is on prevention of pressure injury in prone positioned patients, COVID-19 patients with acute respiratory distress syndrome. It would be of interest to many, and many have attended our webinar on this topic. We have also included a module on the importance of patient engagement in pressure injury prevention. Frequently, it's difficult to engage patients, particularly when they are unconscious or delirious or have symptoms of dementia. But so we have provided some useful resources of how to involve them and how to involve their carers and family members if they can't be involved themselves. And our 5th module is resources for patients, carers, and families. The links to various resources, various available resources in different languages, which will be of use to patients, their carers, and families, but also to health professionals who can simply access this module and download and print the resource and forward it to patients. Next slide, please, Angela. And currently we are working on developing another 6th module on pressure injury prevention in people whose BMI is 30 and over. With increased prevalence of overweight and obesity in Australia, it's a topic of great importance and of great interest among health professionals. I will try to briefly introduce our research project. So usually it's 3 MT, but it will be 1 MT. in my case, so our project was, we have conducted 32 interviews with nurses from 4 participating healthcare services, but this project was part of the multi-component collaborative capacity building project run by Monash partners, which involved 4 participating healthcare services. We aimed to elicit nurses' experiences of pressure injury prevention with a focus on barriers and enablers to pressure care. So I have included some results from NVIVA, and as you see, there are a lot of barriers, and it's just only a small part of all barriers that we have identified. So I will focus on some of them. Can you please move to the next page? Yes, thank you. So many nurses that we have interviewed discussed the change in patients' profile and increasing numbers of patients with overweight and obesity, and related and weight-related skin check issues and repositioning issues, but also they discussed some issues with the access to bariatric equipment and in some cases insufficient knowledge of how to use bariatric equipment. I have included a quote from one interview discussing how difficult to provide pressure care for people whose BMI is over 30. On our question, what are the barriers to prevent repositioning or regular skin checks? One of the nurses said, I would say patients' weight. A lot of us on the ward, we are little skinny minis. We are not very big, and we also have not got a lot of male nurses. The kind of patient cohort that we have get are on the larger size. I will just recount one case, a gentleman who was 260 kilos. We got him a bariatric bed, but there was about 4 or 5 of us. During the night, I called the porters to help me to inspect the skin. They came in, they looked at me, and they said, love, I don't think we can do it. So he did not receive the proper pressure care. Next slide, please, Angel. And I have included a few other quotes to support our main findings. So to those of you who think that it was just only one patient, it's not. So other nurses said that they have a lot of patients whose weight is, whose BMI is 30 and over. So now our question, do you have many bariatric type patients? One of the nurses said they are all bariatric. And providing care for bariatric patients is difficult. Some of them cannot refuse to lie on the side, but many of them can simply not lie on the side. And the nurses can do nothing, just documenting that they were unable to reposition patients on the side. Some issues were with accessing bariatric equipment. Sometimes it takes 24 hours because they request air mattresses through other organizations, through other companies. But one of the nurses said that actually it can take up to 3 days because sometimes on the weekend they don't come. And also we had quite a few quotes and quite a few suggestions for future webinars and for future resources. Many nurses wanted to have some resources on how to use bariatric equipment and how to improve nurses' knowledge of the use of different types of bariatric equipment and how to use bariatric equipment. And I'm so pleased that our guest speakers will present and discuss this topic in details. And Angela, over to you to introduce our guest speaker.
Thanks, Victoria. That was terrific. I'm going to stop sharing my screen now, and it's my great pleasure to introduce our two guest speakers for today. Professor Brigid Gillespie is the Conjoint Professor of Patient Safety and Nursing at the Gold Coast University Hospital and Griffith School of Nursing and Midwifery, based on the Gold Coast campus. Brigid's research focuses on two really important areas of patient safety: compromised skin integrity and teamwork and communication in surgery. Brigid's authored over 175 peer-reviewed publications and several book chapters. She's also won significant competitive funding and is the holder of 5 NHMRC grants. And Brigid is joined today by Dr. Sharon Latimer. Sharon is a Senior Research Fellow and also holds a conjoint position at the Gold Coast University Hospital and Griffith University School of Nursing and Midwifery. Sharon has over 25 years clinical experience and completed her PhD in pressure injury prevention in 2016, and I think also looking at patient engagement in that, Sharon, if I'm right. Her research interests focus on pressure injuries and medication safety. Welcome to you both, and thank you so much for joining today. Over to you.
Thank you. I just want to make sure that you're looking just at the one slide rather than the two. Thank you, and thank you for, I'd just like to acknowledge Professor Carolina Weller and thank her and her team for this invitation to present today. We've done a body of work around pressure injuries. Today we're going to be talking about pressure injury prevention and management in patients with a BMI of over 30 and over.
Brigid, sorry to interrupt you. I think it's still in presenter view and people can see two slides, just to let you know.
Okay, how's that? Sorry. Okay, so I'll just, today what we're going to be talking about is intrinsic and extrinsic factors that contribute to skin breakdown in people with a BMI of 30 or greater. We're going to be looking at some of the challenges in pressure injury prevention, the use of bariatric equipment, patient positioning, focusing on patients and healthcare professionals' safety. And Sharon is going to be presenting the next few slides, and then I'll be presenting the slides that follow, concluding this presentation.
Thanks, Bridge. So obesity is defined as a body mass index or BMI of 30 or greater, and it's calculated by getting an individual's weight and dividing it by their height. Currently, there are 5 classifications of BMI ranging from underweight to obese. However, there are suggestions to expand this classification to 10, ranging from severely underweight to hyper-obese. Within those suggested 10 classifications, there are 6 suggestions for obesity, being obese class 1, obese class 2, severely obese, morbidly obese, super obese, and hyper obese. Now we have to remember that BMI is not a reliable measure of an individual's health. However, it is accepted to show their risk of chronic disease and premature death. So if we have a look, an increased BMI might suggest poor diet and lifestyle. However, this is not always the case. For example, an elite athlete with high muscle mass will have a high BMI. The most recent statistics suggest that 31% of Australians are obese, and we currently rank number 27 in the world in terms of obesity. We know that obesity causes serious long and short-term harm in terms of health, financial stress, mental well-being, and social isolation. And we also know that obese patients have an increased risk of pressure injuries. Thank you, Bridge. So there are a number of intrinsic factors that contribute to the skin breakdown or increased likelihood of skin breakdown in people who are obese. And these are factors that relate to the patient. So often people who are obese will have multiple comorbidities such as hypertension, osteoarthritis, diabetes, cardiovascular disease. In addition, they tend to have increased adipose tissue around vital internal organs, which increases pressure on things such as their heart, their lungs, nerves and capillaries, which can reduce the oxygen and nutrients that are delivered to the skin, vital elements to maintain healthy skin. Also, they can result in reduced mobility and restricted movement. In addition to this, people who are obese will have increased subcutaneous adipose tissue, which results in skin folds, heat retention, sweating. This can all result in the skin drying out and reducing the ability of the skin to be an effective barrier. And finally, people who are obese often experience significant changes to their skin, increased moisture, increased damage and decreased healing. Thanks, Bridge. And this is just a lovely figure from an article that was published by Joyce Tickle in 2015. The citation is at the end of the presentation, and it really shows the interplay of intrinsic factors. Thanks, Bridge. So there are a number of extrinsic factors that contribute to the skin breakdown of patients who are obese, and these factors are away from the patient. So they relate to the clinician, the environment, the equipment and resources. So evidence tells us that some clinicians actually have reduced knowledge around pressure injury prevention and the management of comorbidities. And this reduced knowledge can sometimes influence their confidence in managing patients with these conditions. In addition to this, if there is limited access to specialists such as pressure injury prevention specialists, wound specialists, dietitians, allied health, this not only impacts the care that patients receive, but also the support that clinicians receive as well. Furthermore, hospital equipment, so devices such as IDCs, nasal prongs, can increase the risk of skin breakdown, as can ill-fitting shoes, clothing as well. And finally, access to fit-for-purpose equipment is another factor that can increase the risk of skin breakdown. Thanks, Bridge. This is just another diagram from the Tickle article that shows the interplay of these factors. Thanks. And finally, there are a number of challenges in relation to pressure injury prevention for people who are obese. These are just a few, not an exhaustive list, but access to a multidisciplinary team that involves the patient and family is vital. They will then provide targeted education and support and involving the patient and the family in their care. Encouraging patients to reposition and move is another challenge. Often these patients will experience significant joint pain or a lack of motivation to move. They might have underlying depression, low self-esteem, which all impacts. Another challenge is making sure that these people have really good skin care and overall hygiene to reduce and manage skin moisture, reduce skin dryness, and avoiding infections. And finally, accessing fit-for-purpose equipment that not only is about the correct sizing, but providing access to electronics that encourages their independence. Thanks, Bridge.
So I'm going to talk about the equipment now, and I'd like to just start with when I started looking at the research in this area, there wasn't a lot. There is a small but a growing number of studies that focus on pressure injury prevention in obese populations. So whilst I had a look at some of those, I went back to the clinical practice guidelines, and just particularly the latest guideline that was published in 2019, I also looked at some published evidence summaries. I guess too, for clinicians working in hospitals, there's also hospital policy documents as well. Now I caveat the evidence there because often they're not always updated, but they are another source where clinicians can have a look and see, in those documents for the evidence. So I guess in terms of the equipment, individuals who are overweight or obese, they may exceed the safe weight and dimensions of chairs, beds, etc. and hoists. So it's really important to know the type of equipment that you're using and to know what its limitations are. Now, specialist equipment such as weight shifting is essential to avoid pressure damage. I mean, thinking about what some of the things that Sharon said, these patients are at increased risk already. So we need to ensure that they don't develop any hospital-acquired complication as a result of using incorrect equipment or the wrong equipment. So the choice of equipment is important and ideally to maximise the patient's independence. As the equipment is specialised, staff need to be trained in its use. And probably, in applying that to the practice setting, it would be important if you get a new piece of equipment, a new hoist or whatever, to really speak with the rep that, if it's RJO or whoever, to really understand, to really sort of get to know about the characteristics and the property of that equipment, what it can do and what it can't do. And staff need to be trained in its use. There's a need for wider beds, dynamic mattresses, hoists with high weight capacity and slings. And often that has implications as well for staffing and the number of people required to move the patient and reposition them. So often 3 to 4 people are needed, but this needs to be assessed on an individual basis. So in terms of specialist equipment, the use of repositioning and slide sheets to reduce friction and shear is always good. Hoists and slings should be used for all patient transfers, often on the bed. Bariatric profiling beds must have the ability to change height and be fitted with an adjustable backrest and knee brake. These features enhance patient comfort and reduce the pressure of the heavy abdomen upon the limbs, lessening the risk of capillary occlusion and diminished oxygen levels to the distal tissues, which is something that Sharon spoke about earlier in this presentation. So beds must be fitted with an appropriate pressure-reducing mattress to allow the alternating of high and low pressures. However, in certain cases, dynamic mattresses may impede patient independence due to the possible difficulties with moving independently on this system. The implementation of a static mattress may be better for those types of patients. For typical sitting, the chair and its cushioning should accommodate the patient's size, shape and weight. A dual motor chair may assist the patient to be able to rise independently from sitting, and the chair should also be fitted with an appropriate pressure relieving cushion to reduce the risk of skin damage. Regular repositioning is very important. Non-blanchable erythema may be present later in individuals with overweight or obesity, and as damage occurs in the deeper tissue without it being visible to the naked eye. Many bariatric patients have some degree of immobility, which is a contributing factor to pressure injury development in particular. Common immobility-related complications include skin breakdown, cardiac deconditioning, deep vein thrombosis, muscle atrophy, urinary stasis, constipation, the list goes on. So it is very, very important that these patients are regularly repositioned. So it might be that, the 30 degrees side lying position with the pannus supported away from the underlying tissue. This is based on expert opinion. Also providing appropriate aids to assist individuals to self-position. I think that's really important to try and encourage their independence where possible. Also using appropriate equipment to assist in positioning, such as a bariatric hoist. When unavailable, ensure that there are sufficient people to help in repositioning. Educating individuals around the strategies to self-position and encouraging early mobilisation is important. So giving the patients as much independence as possible, I think, is important, and certainly something that's come out in Sharon's research and other research, that patients want to be involved in pressure injury prevention, and this is one way we can, by giving them that independence to be more self-enabling. So in terms of equipment, check that it's safe for bariatric use. Just because you've got a hoist doesn't necessarily mean it's bariatric appropriate. Consider weight restrictions. Assess the space between the patient and side rails and equipment, make sure that it's sufficient for the patient to reposition. Greater bed widths are required for safe repositioning of dependent individuals. Ensure that the bed is an adequate length to enable correct repositioning of the patient on the support surface. So Wigerman did an observational study and found that the standard 91 centimetre hospital bed provided insufficient space for the individual with a BMI of 30 kilograms per square metre to turn without lateral repositioning. The study showed that individuals who can turn independently, the maximum dimension for the bed would be 91 centimetres, up to a BMI of 45 kilograms per square metre. 102 centimetres for a BMI of 55 kilograms per square metre, and 127 centimetres for a patient whose BMI is greater than 55 kilograms per square metre. So it's important also to assess the support surfaces for bottoming out, which can happen when the surface provides insufficient support because of the excess immersion of the patient. So the patient would not necessarily be supported in the way that they need to be. Now, again, this is based on expert opinion. So it indicates the lack of work done already in this area. There's also no specific evidence around the effectiveness of support surfaces for preventing pressure injuries in patients with overweight or obesity. Now, I can tell you that the results of a recent Cochrane review that was published earlier this year basically says even in patients who are not obese, there's still a great deal of uncertainty in the type of mattress and support surfaces that are suitable to prevent pressure injuries. So this is a whole area of under-research and as yet really a lot of uncertainty around the evidence that currently exists. A pressure redistribution support surfaces associated with a decrease in incidence of PI across a large range of patient demographics, and support surface with enhanced pressure distribution, shear and reduction and microclimate features is also recommended in individuals who are overweight and obese. Pemberton did a small study several years ago around 21 patients who were overweight or obese with a mean BMI 51.4, and they used a low air loss continuous rotation bariatric bed with an advanced microclimate technology for an average of 4.8 days in a critical care unit. In these individuals who had this intervention, no new pressure injuries occurred, and we know that patients in ICU tend to have a higher incidence of pressure injuries as well. So that's just one study and only done in 21 patients. So considerations for staff safety, and all of these recommendations are based on expert opinion. So I guess just to stress that we need to be aware of the manual handling risk for staff in relation to handling patients who are obese and overweight, and stressing that staff need education and training in any piece of equipment that's acquired. A holistic assessment to identify all high-risk breakdown areas is very important. So all of those areas there, including skin folds and thigh folds. It's important also to consider implementing a manual handling plan. So I guess the main point here is there's not a lot of evidence around the different types of equipment and the strategies that staff should use to protect themselves. There is some guidance, and that's what these recommendations provide. But we do need to do additional research in this area, because this is an area that is obviously growing, and even just by the interest today, we know that there are more and more patients that we're seeing in clinical practice who are overweight and obese. So this is a long time overdue. These are just some of the references that Sharon and I used to put together this presentation. And I'd just like to welcome if anyone has any questions or comments. Thank you.
Thanks so much, Brigid and Sharon, for your presentation. Very, very useful information, highlighting the real challenges and the need. Clearly, there's a lot of research, but the need for even more. We did have a request for from one of our participants today, found the information you provided about the measurements for the beds really, really helpful. So we might get that information and include that in the summary of the event that we send out as well. But perhaps you might just revisit those briefly, if that was okay.
Sure, I'll just go back. So this was a study by Pemberton. No, sorry, it wasn't a study by Pemberton. It was a study by Wigerman. It was just an observational study that they did, and it was really just, so what they were saying in this study was that, you know, usually a 91 centimetre bed is suitable for a BMI of up to 45 kilograms per square metre, but you need a wider bed for BMIs. So for a BMI of 55 kilograms per square metre, a bed width of 102 centimetres is required. And for a BMI of 55 kilos per square metre, around 127 centimetres is required. I can send that paper on, Angela, if that's helpful.
That would be terrific, Brigid. We can include a reference and circulate it in the post-event information. Absolutely, yes, thank you. There's also been a request through the chat for the source of the obesity classification that I think Sharon may have referred to at the beginning of her presentation as well. So perhaps we can pop that in the chat if that's possible, or we can circulate it with our summary of the event also. A comment in the chat is that, you know, that the bed mechanics are often not considered perhaps as much as they might be. Often we think that because the bed can hold up to perhaps 220 kgs, it's effective, but there's also that thinking around the surface and can it cope. Any thoughts? And then another comment around actually some of the way some of our hospital wards are designed is a major limitation, isn't it? And some of the rooms that these patients are in are very, very small and not in themselves very conducive to quality care of patients who have a very high BMI. Any comments, Brigid and Sharon, on those two issues?
I think it's really important just to, in my reading around this, and quite honestly, I haven't found a lot of evidence-based work that I would say is level 1 or level 1A evidence to say that any one support surface, and it really does depend on the patient, but I think, yes, I think in terms of the space needed to care safely for patients who are larger is definitely, you need more, the patients need bigger beds, they need stronger beds. I guess in terms of the mattress, they need to be carefully assessed, and I think that would be based on their weight. But I think it's really, again, it goes back to assessing the individual patient. Sharon, I don't know whether you have any thoughts, because you went through and looked at some of the risk factors for these patients.
I suppose one of the things that I'd just like to add is, so one of the recommendations is equipment that is fit for purpose. But if we actually look at what's happening in society, so the Australian government has already highlighted that there is an obesity epidemic in Australia. And if we overlay that with the current pandemic, and we all talk about, COVID kilos, but it's going to be a real problem going forward. We need to move beyond equipment and really look at building design. The widths of corridors. I've certainly seen, people in bariatric equipment being wheeled through a relatively new hospital, and the corridors just don't seem wide enough at times. So, stepping back, I think, is probably something, and really looking at design from a number of different factors is something that is not only needed now, but most definitely into the future, because, this is going to be an increasingly growing problem.
Just a couple of questions that have come through, Brigid and Sharon. A comment here: we struggle hiring larger pressure cushions at our health service. Can you comment on the availability of specialised cushions suiting high BMI patients? Seems to be that getting mattresses may be okay, but chair cushions is particularly challenging.
Well, oh gosh, I can only speak, so Sharon and I sit on the Pressure Injury Prevention Committee for our hospital, Gold Coast University Hospital, and there's always discussion, and this is very anecdotal, so I don't know that I can possibly answer more generally. I sort of give a nuance based on the context. There's always debate around the availability of different types of cushions and the shortage that we have in our hospital, and even with mattresses. It seems to be difficult, particularly on weekends, to get these additional resources for high-risk patients. But I couldn't comment more broadly, I suppose, in looking at what's available in terms of the different companies. When I was doing research on this topic, there are quite a few companies out there that do have different types of cushions and RoHo cushions and whatnot that are quite expensive, and often if you talk to people in hospitals, disappear. But I think it's something that all hospitals struggle with. Sharon, I don't know whether you would have anything to add to that.
Oh no, Bridge, I was just going to say the same things, exactly the same things.
Another question's come through around any information about pressure mapping to check for bottoming out, and if you happen to know if there are any guidelines for this.
I went straight back to the 2019 guidelines, and that's what we have at the moment now. There is work around looking at the precursor to pressure injury development, looking at the subepidermal moisture levels under the skin that can indicate potentially the impending skin damage, underlying skin damage, which can be detected prior to the visual detection of a stage 1 pressure injury, which is non-blanchable, or a deep tissue pressure injury. There certainly has been a lot of work around that, but that's been level 3 work. So that's the sort of work that Sharon and I have been involved in, looking at early detection of pressure injuries, not so much in the bariatric population, but in ICU populations. And Sharon might just talk a little bit about her study that she's been doing, but, you know, I guess that's going back to what the research is on that. I guess that's the comment that I'd make, is that there definitely is the striving to detect pressure injuries early rather than when we see them, because the damage has already been done.
And I'd just like to add that, you know, we're really on the precipice of changing our view on how and our understanding on the development of pressure injuries, and just sort of talking about the subepidermal moisture measures. So we're undertaking a study in the ICU at Gold Coast University Hospital, measuring the sacral subepidermal moisture measure of patients there. And, you know, going forward in the UK and in Europe, they use these devices as an adjunct to pressure injury risk assessment, because as Brigid did say in her presentation, you know, usually when you see redness or erythema through a visual skin assessment, the damage is already started further down in the tissue. So, you know, I think that, you know, trying to really sort of stay focused on what is current evidence and how do you then implement that in terms of clinician knowledge and, you know, managers accessing resources. It's quite complex and complicated, and it's a moving feast, and sometimes it can be quite difficult, you know, to keep up with in amongst our very, very busy and overburdened workloads. So, you know, that's where the team approach, you know, from executive all the way down on your pressure injury prevention committees, you know, having a voice and, you know, collectively trying to bring the evidence at the bedside.
Just a question that's come through, based on the trends in barriers to the availability or knowledge of bariatric equipment, do you see that bariatric equipment and handling should be included in the annual mandatory manual handling for training for staff in health services?
I would say yes.
Look, I think because there's an increasing prevalence of patients who have high BMIs, I would tend to agree. But I think that it would complement what's already in terms of manual handling, rather than making a whole new module. I think that should certainly be incorporated in the current manual handling. I know we have them at the Gold Coast University Hospital, manual handling module, rather than making a new one. But I think it could be incorporated very seamlessly, yes.
A question, do you know of any work being undertaken to set minimum standards for mattresses?
I don't, no, I don't. But look, there is, it might be worth just having a look at the recent Cochrane review that Professor Elizabeth McGuinness was involved in, she and a whole lot of other people, that was published earlier this year. They looked at the effectiveness of various different types of mattresses, and they did some very complex analyses to see which ones were better, which ones work better. And unfortunately, this was based on many, many different studies. And unfortunately, the evidence around these mattresses is still quite uncertain. So, but that might be a good place to start. I mean, even just reading the summary statement at the front of the Cochrane review rather than the 200-page romp through the Cochrane review, but it just gives you an idea as to what the state of the science is at the moment. We still have a long way to go, I think, and this is an area, bariatric, looking after bariatric patients generally, and that's my background as an operating room nurse, and even in surgery we've struggled, and I've seen the development of different equipments that we've had over the years. So I think that we're still learning a lot about these things and how to best and safely manage these patients.
Comment from one of our attendees who works in a paediatric context and is pointing out that this is an emerging area in paediatrics where there's a real lack of evidence and data relating to specialised pressure care equipment in children, with clinicians often resorting to using adult products. The question is, do you have any advice about building capacity in a multidisciplinary acute environment, considering all the factors in bariatric care where there's real evidence lacking?
Can I just add a comment about paediatrics? I don't have a background in paediatrics, but I certainly did read a document that the Australian government published in 2018. So they put together a select committee into the obesity epidemic in Australia. And that particular document does highlight exactly what the participant mentioned, about the emerging problem of obesity in our children and young adults, and really does highlight the future problems that we will have in that population as they not only as pediatrics and young adults, young adults, but as they move into adulthood as well. So the government certainly highlights that as an issue.
I guess in terms of building a multidisciplinary strategy, I think that all the physicians, the nurses, and whoever is tasked with caring for this group of patients, because like Sharon, I'm not a paediatric nurse, but I would think it would be really important for people to get together and discuss some of the issues and identify the problems that the contextual issues that they're finding in that particular setting, and seeing what they can manage, and perhaps looking at documents like that one that Sharon mentioned to see if there are any other, because that certainly is an emerging area, and I think one that will develop hopefully in research to come. But I think that would be the first thing that I would do, is get everyone together to see what the issues are, identify what the issues are, and look at strategies that can be implemented to address some of those issues. I won't probably be able to address all of them, particularly if, I think Sharon's comment before around the equipment being fit for purpose. This equipment may not be designed for paediatric patients, and that's problematic. Would it be then that through the procurement department within the hospital, are there companies that have equipment specifically designed for paediatric patients in terms of support services, etc., etc.? I think that might be, something that might be worth looking into as well.
Perhaps a future webinar topic, looking at this in paediatric context. There's also a comment here about the importance of being holistic in our management of patients and addressing the underlying root causes or factors relating to lifestyle, nutrition and psychological factors such as trauma-informed counselling, and referring patients to appropriate services that specialise in those fields. The question is that, with a view to helping people to perhaps reverse their condition, the question is there a form for managing high BMI pressure injury that includes that vital intervention, linking people into practical resources to enable implementation?
Look, I'm not aware of anything. I think that, and Sharon can speak to this, but I think that, you know, a holistic assessment is essential. There are going to be modifiable factors and non-modifiable factors, and I think that it's looking at those factors that are modifiable, which obviously include diet and exercise, and then, you know, I guess working with the individual, you know, but I guess that's something, you know, that would happen for patients in hospital for such a short period of time. Those sorts of systems and processes and structures need to be set up before the patient is even discharged. So when the patient comes into hospital, we should be planning when they're going home. And so those sorts of processes should be in place so that when the patient goes home, there is that kind of follow-up, you know, by those other, you know, the dietitian, the GP, and, you know, that kind of thing. So, but I'm not aware of anything in terms of this population that would specifically target those things, but I think it is a holistic approach.
If I can just add, and I'll just talk about patients generally. We see them for such a short period in their life, and they are bombarded not only with information from a range of clinicians, but they're actually trying to cope with their current medical condition, surgical condition, you know, worries of, you know, their family at home, jobs, all of that sort of stuff. So I think that, you know, one thing that we can do as clinicians is to just provide a couple of important messages. And Bridge, I'm thinking about the intact care bundle, patient education in preventing pressure injuries. So we recently rolled out a education bundle for patients, and generally for all patients, adults, about the 3 things that they can do, 3 simple things that they can do to prevent their likelihood of developing pressure injuries. Because we could tell them 1,000 things, but the 3 things that they could do would be to keep active, keep mobile, look after their skin, and eat a healthy diet. Now that bundle is available in 9 different languages, and it's on the TV screen at the bedside. And patients can just, you know, go through the video or look at the brochure or look at the poster. And overwhelmingly, when we interviewed patients, they said that bundle provided them just with simple things for them to think about that weren't overwhelming, that were things that they could not only do in hospital, but then could also transfer out into the communities. So the 3 points were keep moving, look after your skin, and eat a healthy diet. And we'd be probably willing to share that resource, Bridge?
Absolutely, absolutely.
And overwhelmingly, patients love the resource. And when we showed nurses, they loved the resource as well, because they were able to continue with their assessment, show the patient the video that went for about 6 minutes, and then answer the patient's questions. So I suppose, you know, it is about, you know, having that targeted approach, not overwhelming patients who are already overwhelmed. Nurses are overwhelmed. Everyone in the healthcare system is overwhelmed with work in a really short, compressed period. because as Bridge said, they come in and out very, very quickly. And so if we can sort of give them just simple messages delivered in acceptable strategies such as a video or a brochure or a poster, that might be one tiny little way that we can help them.
Just mindful of time, one final, I think we've recognised that you're right, patients are in hospitals for very short periods of time. Just your thoughts about research focused on these issues in the community setting, which I guess might also be helpful in terms of preventing patients from coming into hospital to begin with.
Well, look, I can't tell you the number of people who have asked our group about what research we're doing in the community, and there is a dearth of research, unfortunately. We have focused most of our research in the acute care setting. However, that said, we are starting to consider ways that we can move into the community to do this kind of research, because we know that once a patient leaves the hospital, unless they get good GP follow-up, and if they've got a wound of any sort, if it's a pressure injury or anything else, how are they followed up? Who's following them up? We don't even know what the prevalence of these wounds might be in the community. So I think in terms of what we're doing research-wise, we're certainly looking at how we can build our links with community organisations to further do research and work with community organisations to do research around these kinds of things. So I guess watch this space.
We could keep talking for a long time, and I'm just aware that we're out of time, but Brigid and Sharon, sincere thanks to you for joining us today. We will, just to reassure everyone, we will circulate the resources that have been referred to in today's presentation in the summary, and we'll also make a link to the session available. Thank you so much. We really appreciate the opportunity to collaborate with you, and thanks to everyone for joining us. Please be in contact with the Monash Partners team if you have ideas for future events, and thanks so much for your attendance today.